Greetings and welcome to this latest teleconference by MS Focus. I'm your host, Chris Payne, for MS Focus, and I'm joined today by Dr. Ben Thrower, who will present for you Ask the MS Expert. After his opening, we'll open it up for questions and comments. Now I'm delighted to introduce our speaker. Dr. Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center. He previously served as medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the senior medical advisor for MS Focus and enjoys contributing to our quarterly magazine. When he isn't dressing up as Jack Sparrow the pirate, he can be found playing with his two wonderful grandchildren, Sam and Opal. We're delighted to have him join us this afternoon. Dr. Thrower, thank you for being with us, and now I'm going to turn it over to you.
Great. Thank you, Chris, and thank you to all of the other staff at MS Focus. On behalf of the medical community, the MS community, we really appreciate everything that you folks do. I hope that anyone who is in potential harm's way with the tropical storm coming in, whether you're in South Florida or South Georgia, please stay safe, everyone. So this is one of the most fun things I think that we do, and that is the freestyle Q&A. There's no format here. I would guess the only sort of ground rule that we would ask is try to keep your questions as broad as possible, questions that would apply to lots of people. We try to avoid telling our personal stories if we can, just so that we can get us through as many questions as possible. I get long-winded enough as it is. So with that, we'll take some of the first questions, Chris.
All righty. If you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and you will be able to unmute and ask your question. So let's get to some of those questions. We're going to start with a question from Q&A. How is active secondary progressive MS defined?
Yeah, so a while ago, we divided secondary progressive MS into active and inactive. Prior to that, it was just secondary progressive MS. The definition of active secondary progressive MS means that you're either still having relapses or you're still having new lesions on MRI. Could be both, but it has to be at least one of those things, implying that there's still some active ongoing inflammation. I would argue in the past, we probably would have tended to put a lot of those people in the relapsing remitting category. So it is kind of this gray area between relapsing remitting and traditional secondary progressive MS.
All right, we're going to invite Karen here. Let's see, yeah, I have a hand up from Karen. And for some reason, I cannot get her to, respond. So, well, there we go.
The unmute just came in and I clicked it.
There we go.
Quick, as we get information about our MRIs, for instance, if you have an MRI from the last couple of years that has you as stable, no new lesions, but I've heard about smoldering MS, and does the traditional MRI that we get look at that type of damage that's being done? And do all smoldering, if you have them, do they eventually become lesions that are perceived on a regular MRI?
Great question. And the honest answer to that is maybe on both accounts. So traditional MRI does a great job of picking up both old and new lesions. But what about a lesion that is kind of active, or as you say, smoldering? So it's maybe getting just a little bit larger, maybe not, horrible active inflammation, but just this kind of low level smoking ember, if you will. So if the lesion is slowly enlarging, we may be able to pick that up with MRI. It is a challenge, though, to be really honest. So if it's not actively inflamed, but just again this low level smolder, it may be tough for us to pick that up with traditional MRI. There are some new research techniques with MRI that may allow us to do that. There's a lot of interest in volumetric studies, so studies that or computer generated or computer programs that would do these volumetric studies, measuring the lesion volume, looking at the volume of deep gray structures. But even those, there's not been a 100% agreement that these are completely ready for prime time outside of research. So we think the smoldering lesions are important. We may be able to pick them up if the lesion enlargement is significant enough, but not always.
All right, we have a question in the chat. I had all my COVID shots plus 2 boosters. I caught Omicron, and following that, I had painful neuropathy in my feet and legs. Did COVID exacerbate this reaction?
So that's also a great question, and I would say it's possible, but it's going to require a little bit of medical detective work. And at the end of the day, it may be an educated guess as to whether there's a definite, cause and effect. We can say, well, they're clearly associated. You had the neuropathy come on after COVID, but did the COVID cause that? We're really still learning all of the things that COVID does in humans in general, let alone multiple sclerosis. There have been recent studies that have shown that the incidence of MRI changes in people in general, not specifically the MS community, just people in general. There's a lot of stuff potentially we're seeing on MRI after COVID infections. We don't know what the clinical significance of this is. Is it possible that a COVID infection could cause a pseudo exacerbation of a person's multiple sclerosis so that you would have a new MS symptom? Well, we know any viral infection can potentially do that. So I think it is distinctly possible that COVID could have caused the neuropathy that you're dealing with now.
All right, we have a question from Jen. Can you please share your knowledge on brainstem lesions? I had one and I am afraid I have another. My mobility is fully back, but still have sensory issues left 1 year later.
So different areas of the central nervous system, brain, brainstem, spinal cord, are more forgiving than others if you have a new MS lesion. So we know, for instance, that for every clinical relapse that a person with MS has, there can be 5 to 10 lesions in the brain itself that maybe haven't given the person any obvious symptoms. Maybe the symptoms are there, but they're just subtle. The brainstem and the spinal cord are much less forgiving. Typically, if you put new areas of demyelination in the brainstem or the spinal cord, you're probably going to have a symptom from it. There's just a lot of vital structure packed into a very small area in the brainstem and with the spinal cord. So depending upon where in the brainstem the lesion was, you can certainly get things like double vision, facial numbness, speech difficulties, or problems downstream with gait or coordination. Just because you've had a brainstem lesion or a spinal cord lesion, that doesn't necessarily mean that you're at high risk for more brainstem lesions. MS is unpredictable and sporadic. So, a lesion could pop up in the brainstem this year and you may never have another brainstem lesion, but we do definitely, we pay attention to all MS lesions. We do appreciate that brainstem and spinal cord lesions are sometimes a little more problematic for people with MS just because they tend to cause more symptoms.
As a reminder, if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your questions anonymously if you choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you will be able to unmute and ask your question. Speaking of which, we have Jim. We have a question from Jim. Hopefully we'll get you unmuted here in a moment.
Okay.
There
Hey,
you are,
Dr.
Jim.
Hey, Chris. I've got a question, peripheral neuropathy as well, and it seems to be related to the temperature changes as it gets cold. I get fatigue from the heat. I get pain and increased spasticity in the cold. I have upped my baclofen with the spasticity, which seems to help. But have you got any thoughts on helping with the neuropathy, especially in the toes?
So, hey, Jim, how are you doing? Good to hear from you. So when we say the term peripheral neuropathy, we have to be a little bit careful because peripheral neuropathy is that's a class of problems that affect the peripheral nerves. So that really is separate from MS. If you have a peripheral neuropathy, that would not be a direct result from your MS. The symptoms of neuropathy are very, very similar to the sensory symptoms we see with MS. So when someone with MS says, I'm dealing with peripheral neuropathy, what they usually mean is I've got burning and numbness and tingling in arms or legs. And it's similar to the symptoms that someone with peripheral neuropathy would get, but it's really from a different thing. Now, there are people with MS who do have peripheral neuropathy because they've got another health problem, so they're dealing with two different things. Typically, with neuropathic pain, the hypersensitivity, burning, numbness, tingling, we're looking at one of two classes of drugs for that. We're looking at either things in the anticonvulsant class, gabapentin we seem to use by the bucketful, gabapentin, Lyrica, those types of medications, carbamazepine, oxcarbazepine, those are all anticonvulsants that can be used to tone down that neuropathic pain. We also use antidepressants, things like Cymbalta, Elavil, or amitriptyline, which has been around forever, are drugs that, because of the way they work for mood, those same neurotransmitters can be targeted to decrease pain. So those are probably the two most commonly used classes of drugs. We do use cannabinoids, medical marijuana. If it's a very localized area of discomfort, we might look at topicals, things like Lidoderm, CBD lotion. So any of those things are in the toolbox to help manage that type of discomfort.
All right, we got a question from Tess here. It's a little long, so I will do my best to get through this. Forgive me if I screw any of this up, Tess. It's actually more than an informative statement. I talked to my neurologist about stopping Copaxone injections at now 64 years old. I told him I heard at this age it was relatively safe to do so after listening to all sorts of webinars. He replied that he had never heard or read that. This scared me right away that he had not. Where did he go to med school? He then said it was his suggestion that I remain on it because if I stop and get worse, getting back on, it might be too late to stop progression. What are your thoughts, Dr. Thrower, on what he is saying? Thank you.
Yes, I can't vouch for any of his personal qualifications, but healthcare providers, I mean, we all have different levels of information, and I will say one of the challenges for some of our community neurology colleagues is if they're not focusing just on MS, they're trying to keep up with just this fire hose of information, because maybe they're working with MS and with Alzheimer's and with epilepsy and with migraines, and all of these fields have so much new data coming out that sometimes people do they miss things, and it may not imply that they're a bad doctor. Maybe that they just missed that one study. So there was the Disco-MS study. That was the acronym for the study that came out this year. It was really discussed first at the Consortium of MS Centers meeting this past May. And you could certainly if you just Google that Disco-MS, DISCOMS, you can find the study, and it tried to give us a real world look at what it would look like to stop a DMT, most commonly things like glutamer or interferons, in a group of people over the age of 55, mainly over the age of 60. And it was a funny statistical design for the trial, but the take-home message was that both groups, both the group that stayed on treatment and the group that went off treatment, really did pretty well. There were very, very few relapses. There were very few new lesions on MRI. And the relapses that we're seeing tended to be fairly mild. That study would make us feel more comfortable in stopping Copaxone in someone age 64. But we always have the caveat that it really comes down to the individual's comfort level. What we would never want to do as a healthcare community is tell you must stop this, or you must stay on this drug. It really comes down to risk benefit ratios. So we can look at that study to give us guidance, but we want to think about what's your comfort level? What is your hassle factor for being on a given disease modifying therapy? What is the expense of that therapy for you? Is there any health risk to staying on a treatment? The beauty of a drug like Copaxone is really is very, very little health risk. It's our only DMT that we don't do any blood monitoring with. So it usually comes down to just the hassle of doing the injections or the expense of the medication. So that was the study that was out there. And people can certainly take a look at that and use that to help make an informed decision about whether they want to stay on treatment or discontinue it.
All right, our next question is from Anonymous. Thoughts on edibles or gummies to help with pain and sleep and energy and focus? Are they safe with DMTs? Are they safe with MS?
So cannabinoids, the active, which is the main chemicals that we're looking at in hemp and marijuana. So usually we're most focused on THC and CBD. If people, we have a MS Focus program. If people want to take a look at that, they can reference back to that, where we give kind of a broad overview of what the different cannabinoids are and what some of the data shows. So when we look at products that contain THC, there is data out there suggesting that they can have benefits for managing spasticity and spasms, neuropathic pain, the burning hypersensitivity that we talked about earlier. And there is some data for overactive bladder, for urinary urgency and frequency. I think that the safety of cannabinoids, whether it's edibles, gummies, is probably very similar in the MS community as it is to anyone else. I would encourage people to think of them as medications. Think about the quality, the source where you're getting them, laboratory testing, and realize there can be drug-drug interactions. These drugs are metabolized through some of the same pathways that medications can be. There are a whole list of things where there might be drug interactions. Generally, that risk is pretty low. I don't know of any significant interactions between cannabinoids and disease-modifying therapies. These would be more your symptomatic therapies.
All right, a reminder, if you have a question or comment, you can ask it using the Q&A button in the app, which allows you to send your question anonymously if you choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you will be able to unmute and ask your question. And our next question is from Kellyanne from Facebook. She asks, I have progressive relapsing. Will it go to the next stage of MS?
So So progressive relapsing is one of the categories of MS that we used to use. It's actually been dropped. So now when we talk about the subtypes of MS, we talk about relapsing remitting, which is the lion's share of people with MS, secondary progressive, and that's kind of subdivided into active and inactive, and then primary progressive. Some people would include clinically isolated syndromes, which is your very first attack, as maybe another form, but we've kind of dropped the progressive relapsing. So, we do talk about relapsing forms of MS, and if the person is still having relapses, the goal is to hopefully prevent future progression by being as aggressive as we possibly can with our existing disease modifying therapies. We really feel like there is a decent chance that if we can't prevent all progression, that at least we can slow things down dramatically until technology can catch up with us and give us more treatment options, and hopefully in the future repair options to hopefully reverse any disability that people with MS have accumulated.
Our next question comes from Judy. Is there any data showing or being collected on the incidence of MS patients clinically relapsing?
Not sure I understand that one. I mean, so we're always collecting data on relapses, but whether it's an MRI relapse, so just new lesions on MRI, or clinical relapses, people having new clinical events, or both. So if you're talking about clinical research, yes, I mean, that is always one of the endpoints in a clinical trial, looking at annualized relapse rate, severity of relapses, recovery from relapses, and then in the clinic itself, just in monitoring people. When we think about what is our goal for a disease modifying therapy for a person with MS, there's an acronym called NEDA, N-E-D-A, no evidence of disease activity. NEDA means you have no relapse, no new lesion on MRI, no progression of disability. In other words, you've gotten an A+ on your MS exam, and that's our ultimate goal for any disease modifying therapy in MS.
Our next question comes from Daryl from Facebook. He asks, my body adapts to medication really fast. I have lost 50-ish pounds. I exercise most days at least 30 minutes a day. Last Ocrevus treatment was the first time that I didn't feel like my body needed the medicine. Is that a change in my body needing the Ocrevus, or is that my body lessening the effects of medication with the weight loss and better health?
It's a great question. And so we do tend to use a one-size-fits-all dose of a lot of our medications, including Ocrevus, or our standard dose of Ocrevus is 600 milligrams per infusion. Some people lower, some people were doing a modified dose of 300 milligrams, but I mean, he's right. I mean, we are doing the same dose in a 100-pound person that we would do in a 250-pound person. Ocrevus is very similar to a medication called rituximab. So they're both anti-CD20 monoclonal antibodies. Way back in the day when we were first researching rituximab in MS, we did a weight-based dose, but then the decision was made at some point along the line that there wasn't much variation, and so that there was a decision made to use the same dose per person. The beauty of a drug like of Ocrevus is that we can look at your blood work and tell what kind of response you're getting to that medication. Are you someone that is repopulating your B cells early, and so that maybe we would need to do a more frequent dose? Your issue sounds like it's the opposite. Could we go with a lower dose? Your treating healthcare team can look at your labs and say, okay, are you still suppressing the B cells that you want to suppress with Ocrevus, or is it doing too much? Is it starting to hit T cell subsets? Is it starting to work on immune globulin levels, which is not what you want Ocrevus to do? So they might be able to give you some guidance by looking at your blood work. And sometimes we just do our own adjustments based upon how the person feels. So if you feel like you're doing really well on that dose, but maybe you could do less, there might be a trial period where you do go to a 300 milligram dose rather than the 600. But your team should be able to use your labs to help give you some guidance on that.
We have a question from Teresa. If I'm always having symptoms, never in remission, would I not have relapsing remitting MS as I'm going to say diagnosed, but progressive?
Yeah, that's a great question. And it's a really common one. So when we say relapsing remitting, that remitting part, so there's a tendency for us to think of remission as being symptom free, and that's not the case. So even when people are in remission with relapsing remitting MS, they tend to have baseline symptoms. It is the very rare individual with MS who is completely symptom free on any given day. So remission simply means that you have a period of stability. You're not having relapses, you're not having progression of disability. To make life a little more challenging, so whatever your baseline symptoms are, maybe it's fatigue, maybe it's spasticity, maybe it's bowel and bladder symptoms, that baseline can move. You're going to have good days and bad days. If you are under a period of stress, maybe you're having, an increase in your baseline fatigue. So that baseline during remission does have some wobble to it. So all of those things put together do make it a little difficult sometimes for people to wrap their head around the fact that I'm in remission, even when I'm having symptoms. So yeah, that we get it, that remitting part of relapsing remitting that is a little challenging to when you're still having symptoms.
If you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your questions anonymously if you choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you'll be able to unmute and ask your question. We have a question from Facebook from Beth. My hubby has had new lesions so far every MRI. He just had his second infusion of rituximab. Should we change medication or should we wait to see if rituximab will work? Next MRI is December 9th.
So we clearly want to put that fire out and not see new lesions on MRI, regardless of what therapy, including rituximab. The general rule of thumb is we would love to give any given disease-modifying therapy a year to work. I would say, if you've received 2 doses of rituximab and the fire is still not put out, you're still seeing new lesions on MRI, you're getting very close to that point in time where a decision is going to be made to, okay, this is not okay. We need to do something differently. There are a lot of options of what to do differently, with just like with Ocrevus, with rituximab, this is one of our B cell therapies. We can look at your labs. And so one of the questions, if someone's still having new disease activity on rituximab, is on the laboratory side, are we suppressing the B cells the way we want them to? Every now and then we run into someone who doesn't respond to the standard 6-month dosing of rituximab, and we need to go more aggressively. So it may be a dosing issue with rituximab, kind of the opposite of the gentleman we just talked to, where he's feeling like he needs less. This may be a person who could do more frequent dosing, or it could be, that the rituximab is just not going to be the magic bullet we're looking for. As good as drugs like rituximab are, we don't have any one MS therapy that's perfect. And so it may be that if the labs look good and if it's not felt that a more frequent dose is going to do it, it may be that a move to something different, maybe in the future.
All right, our next question is from Lori. If you are inactive SPMS, should you still be on a DMT?
I would say absolutely yes. So active means you're still having relapses or new lesions on MRI, which means that immunologically you still have active inflammation. And so active inflammation is the target for any of our DMTs. You don't care which DMT you pick out of the toolbox, ultimately they are all anti-inflammatory. And so I would say absolutely yes. If you've got active SPMS, I would encourage that person to stay on treatment.
All right. We have another question from an anonymous attendee. Can MS cause a high ANA titer?
Titer, yeah.
Titer, thank you.
Um,
But let me finish up their question here. They also have a note here saying a ratio of 1:1,280 homogeneous. I have done all the tests for lupus twice now, and all come back negative except for the ANA. Wondering if it's my MS.
So MS does not directly cause an elevation of the ANA titer. So we do see this sometimes where people with MS, and I see it more commonly in women with MS, they'll have ANAs that are abnormal and you follow it over time and it goes down, and we have them see the rheumatologist, and the rheumatologist does the big, workup for other autoimmune conditions like lupus, and it all comes back negative, and this ANA just kind of bounces around. I think what that may represent in some people is just a generally overactive immune system. So it's almost like the immune system is flirting with having another autoimmune condition, but it's not there, and hopefully never gets there. So we do see that. It's of all the other immune markers that we do looking for other autoimmune conditions, I would say the ANA is the one we see it most commonly with, where it's just this annoyingly positive ANA with no clinical evidence of actual lupus. And what we usually do is just repeat it periodically and watch clinically to make sure the person isn't developing any symptoms of that would go along with lupus.
All right, our next question is from Lori. Let's get you off mute. Lori, are you with us?
I am. How are you?
I'm doing well.
I want to clarify. I may probably type the question in wrong. We'll blame MS. But my question is, if I am inactive SPMS, what's the thoughts on continuing with a disease modifying?
That makes more sense. So inactive, so no relapses, no new lesions on MRI. So I would throw just a little caveat in there. So when we think about using the secondary progressive MS label, so especially inactive, if you're still on a disease modifying therapy, how do we know that it's not the disease modifying therapy that is making you inactive? And there's no right answer to that question. So could it be that if we took a person with inactive secondary progressive MS off of their DMT, now we'll see disease activity. So we'll see relapses and new lesions or new lesions on MRI. I think the length of time that someone's been stable or inactive makes you feel better that maybe they really are inactive and that they could go off of their DMT. But that's the struggle I have in the real world, with being very dogmatic and black and white about making that call one way or the other. Ultimately all of these subtypes of MS that we discussed, relapse and remitting, secondary progressive, primary progressive, they were really used to describe the natural history of MS, or MS not on a DMT. So when we put someone on a DMT and we modify that natural history, it does make that determination a little more challenging. Does that help?
It does. Thank you.
Yeah.
All right, we have a question from Deb. Let's give her a moment here. Deb, are you with us?
Thank you. Is progressive disease only determined by MRI activity, or would physical decline without relapses be included in this definition?
So really progressive MS is more of a clinical definition than an MRI definition. And I think I may know where you're going with this. So, one of the stories that we see every day, and every MS center around the country, I guarantee sees this every day, is the person with MS who comes in, they're on a DMT, their MRI is stable, they have no relapse, but they're doing a little bit of this. They're seeing some progression of symptoms. What does that represent? Is it progression of the underlying disease itself, or is it something else? And this is an area of a lot of research and discussion in MS, and ultimately we hope we have something to do with it. Just I want all of the listeners to know, when that happens, we say you have a stable MRI and you're not having relapses, but you feel like you're progressing, we hear you, we believe you, we know it happens. There is a strong suspicion that what that may represent for a lot of people is loss of neural reserve, that the MS itself may not be changing. It's your brain and spinal cord's ability to adapt to the prior lesions, to the prior injuries from your MS that is changing. We all lose neural reserve after about age 30. So if you have a pre-existing injury from MS, your progression that you're seeing now could represent your body's loss of ability to adapt to an old MS lesion. That has big implications, because if that's what drives a lot of progression in the setting of stable MRIs, that's really not your MS changing, that's loss of reserve. And moving to more aggressive DMTs, switching DMTs may not address that problem. We know that keeping people as fit as possible, keeping people in good condition, does help maintain neural reserve. But that loss of neural reserve really points to is the drastic need in our world for neural repair, or strategies that improve neural plasticity or rerouting of neural pathways to get around old areas of damage.
Our next question is from Christy. She's on Facebook. She asks, I've had MS since I was 32, now 54. I also have a pacemaker that limits testing, MRI, etc. Is there any other tests that can be done to find out the progression of MS?
So right now we do have two things that might be helpful. One is easily available, and that's called OCT, optical coherence tomography. And I will say it's a very indirect way of kind of telling us what's going on in the brain, but it might be something that you could follow over time to give you a rough surrogate measure of what's going on in the brain. So OCT, or optical coherence tomography, can be used to measure the thickness of the retinal nerve fiber layer. Ophthalmologists have been doing this test for years. It's quick, it's easy, it takes less than 5 minutes. There's no pain associated with it. The optic nerve fiber, the retinal nerve fiber layer, is a correlate of brain volume. So you could say if someone's losing retinal nerve fiber layer quicker than we would expect it, there is a normal loss on a decade basis for age. If it's going faster than that, then you could say, well, maybe that reflects what's going on in the brain itself. You would have to rule out any other eye conditions that might account for that. Things like glaucoma can also cause that loss of retinal nerve fiber layer. The other test would be neurofilament light chain testing, and this one is a little tougher. So neurofilament light chain is it can be done on blood or spinal fluid. Obviously, we'd much rather do blood. It is a measure of axonal damage. And so there is indication that when MS is acting up, that there are higher levels of neurofilament light chain. There are some commercial assays out there. I would say outside of research, this is in its really early stages. We've met with some of the groups that are working on neurofilament light chain, and my personal feeling is I'm not quite sure it's ready for prime time yet, but I think it's getting close. Excuse me.
If you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you choose. If you or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you will be able to unmute and ask your question. And our next question is from Becky. How does Ocrevus help to slow brain shrinkage? Is it more common in PPMS not to have active lesions?
So Ocrevus is one of our B cell therapies. So it's an anti-CD20 monoclonal antibody. It basically binds to the CD20 receptor on B cells and targets them for elimination. So it's ultimately an anti-inflammatory drug. We think inflammation is part of what drives atrophy ultimately. So by causing inflammation, you're causing damage to axons and neurons, and ultimately this is what part of what drives inflammation. Big inflammation is less common in primary progressive MS than it would be in relapse and remitting MS. It is less likely that you would see active inflammation on MRI in primary progressive MS. That was one of the things that some people criticized in the Ocrevus primary progressive study, is that when you looked at who it worked in primary progressive MS, there was a tendency in that study to say, well, it tended to work more in people who had active inflammation on MRI, which is a little unusual in primary progressive MS. So did those people in that trial really represent the average population of people with primary progressive MS? It is our only FDA approved treatment option for primary progressive MS.
Our next question is from Doris. What is the distinction between primary progressive and relapsing remitting?
Yeah, so primary progressive is really its own distinct little subgroup. So it is the least common form of MS, representing somewhere between 5 and 10% of the MS community. So primary progressive MS is more common in men versus women, which is in contrast to most MS. It tends to start a little bit later in life, typically in the 40s or 50s, whereas relapsing remitting MS more in the 20s and 30s. And there are no relapses. There is just slow progression. Primary progressive MS typically is more of a spinal cord than a brain issue. So it tends to be more of a walking issue than anything else. And it's just slowly progressive over years, whereas relapsing remitting MS by definition has relapses. So you have attacks, you wake up one day or something comes on relatively suddenly where you have a new or worsened focal neurological symptom, and it has a period of time where it frequently gets better early in the course of relapsing remitting MS, whereas with primary progressive, we just see this slow progression over time.
Our next question is from Judy. Is there any data showing or being collected on the incidence of MS patients clinically relapsing during the process of stopping a DMT and going into a new classification DMT, especially in relation to the B and T cell depleters? Would there be any rationale to staying onto an old DMT for a month while starting a new drug?
Yeah, so those are wonderful questions, and there are a lot of variables in there. So a lot of that's going to depend upon what DMT you're talking about. So when we're thinking about transitioning from drug A to drug B, we would like to make that as smooth as possible, and we don't want to leave the person unprotected. So it really is going to depend upon the medication. So realize let's take, say, Ocrevus, for example. The Ocrevus molecule and rituximab as well really only stick around in our system for a short period of time, a week or so. But the immune effect lingers for 6 months or longer. So even though the drug itself may be gone from your system, the immune effect and hopefully the protective effect is going to linger for quite a bit of time. We have to be careful when we're transitioning from one DMT to another that we're not ganging up on your immune system too. So while we don't want to leave you unprotected for your MS, we also don't want to leave you immunocompromised. So for instance, with typically with an Ocrevus medication, I usually like to have, if I'm going to stop that drug and start something else, I would like to have the new drug started probably at the 3 to 4 month mark. So maybe the B cells are starting to come back a little bit, but they're not back to baseline such that I've left the person unprotected. And now I've got the new DMT. You have to think about how long does it take that new DMT to have its onset? Is it something that's going to set up shop within a month or so? So those are all the thoughts that go into that transition. And again, there are a lot of different permutations depending upon what the starting drug and what the transition, the new drug is going to be.
Our next question comes from an anonymous attendee. Do you recommend taking probiotics? I read an article that it could help with symptoms and prevent relapses. If so, what brand or kind do you suggest?
So probiotics are a way of potentially sort of maintaining a normal gut flora. So when we say gut flora, we mean the normal bacteria that are in your gut. We know that the gut is your first line of defense immunologically, and your normal bacteria in the gut are an incredibly important part of that. We also know that if you look at a person with MS who is not on any treatment, their gut flora looks very different from the general population. And I will say the other word for flora is sometimes biome. So that's the other phrase that people will hear. So clearly there's something there. When you put a person with MS on a disease-modifying therapy, their gut flora starts looking more like the general population. So does being on a probiotic, does it make sense? Maybe. I would say I don't think we have enough data yet to say it absolutely is a good thing. I don't think it's a bad thing. The other reason people might want to think about a probiotic is if you're getting courses of antibiotics periodically, maybe for a UTI or something. Well, we know that antibiotics have the potential to wipe out your normal gut flora. So taking a probiotic is one way of trying to keep that normal gut flora or biome in place. As for brands, that's a tough one because there are so many things out there. I will say that I think we have some things on MS Focus from people like Megan Weigel. She's a nurse practitioner in Florida. She does a lot of work with integrative and alternative therapies. I would certainly take a look at anything she's put out. I've sometimes just gone old school. I mean, there are a lot of products out there. There's the old, and I'm blocking on the name of the brand now. It's been around forever. Probiotic. I'll think of it in a minute. We could post it on it, but it's one that's been around forever. You'll see it on the shelf, which is it's CVS or Walgreens. People can get pretty fancy with probiotics, and there is the thought that the more the more number of bacteria, the better. I will say occasionally when people start probiotics, they sometimes feel a little bloated or crampy. So you may have to play around some with dosing and brands to find one that's right for you.
Our next question comes from James. So the never-ending COVID question. My doctor and neurologist have really not recommended the boosters. I had the third. The new one is a wild card. Evusheld?
Yeah. So starting with the new bivalent booster. So most of what we're dealing with in the COVID world right now are Omicron variants. The reason for the new bivalent booster is that our original vaccines and boosters were for the original COVID, and for Delta, they gave pretty good coverage, but they didn't seem to give great coverage against Omicron. People could be vaccinated with our original vaccines and boosters, and they still got Omicron. So the question of whether you should do the new bivalent booster really comes down to what your risk tolerance is. So if the the bivalent booster is the only vaccine we have that seems to offer protection. I'll play devil's advocate. The critics of the bivalent booster, and there were 2 members of the FDA vaccine advisory panel who were dissenting votes and recommended against approving the bivalent booster. Their concern is that we are approving it based upon the laboratory assay. We're using neutralizing antibodies to judge the efficacy of this new bivalent booster. That's the way that we have traditionally evaluated the efficacy of flu vaccines each year. And what both of these dissenting voters pointed out was that, well, flu's been around forever. These vaccines for influenza have been around forever. We've got a known track record of evaluating the flu vaccines using neutralizing antibodies. COVID is still a relative newcomer, and this bivalent vaccine is a definite newcomer. So they weren't comfortable letting only the neutralizing antibody assay serve as a measure of efficacy. That said, I certainly wouldn't discourage anyone from getting the bivalent booster. Omicron is just as varied as a lot of our other COVID variants. We see people that are getting nuisance type symptoms, and some people say, it was just a cold, and other people getting pretty sick with it. If you are in a position where you might not make good antibodies to a COVID vaccine or booster, primarily meaning you're on a disease modifying therapy that might attenuate your antibody response, that's where Evusheld comes in. Evusheld is a way of getting COVID protection that doesn't require a vaccine or booster. We're just giving you the antibodies. So Evusheld is 2 monoclonal antibodies against different portions of the spike protein with COVID. It's administered as 2 different intramuscular shots, 1 in each hip, and it appears to give at least 6 months of COVID protection, including against most Omicron strains. There is some data that suggests that maybe this BA 4.6 Omicron subvariant might not be as responsive to Evusheld, but that seems to account for about 7 to 10% of COVID cases. So still, Evusheld seems to give good protection against most COVID. If you're on a DMT, including most of our B cell therapies, Ocrevus, Rituxan, Kesimpta, and maybe our S1P modulators, so your Gilenya, Mayzent, Ponvory, I would think about maybe talking to your doc about Evusheld for some protection. Probably could at least have the discussion with Mavenclad. Mavenclad. Mayzent is in that S1P drug. So any of those, I would think about talking about Evusheld with your healthcare team.
Our next question comes from Jim. I have RLS, and it has interrupted my sleep. I've tried many sleeping pills that eventually stopped working. My doctor prescribed quinine and tonic water. I actually slept well and had a great night's sleep.
So one of the challenges that I think a lot of us have is, so restless leg syndrome, where you get the uncomfortable need to move at night, those symptoms overlap a lot with spasticity and spasms from MS. And sometimes we struggle a little bit with whether someone has true restless leg or whether it's a funny form of increased muscle tone from their MS, because the symptoms overlap a lot and they both tend to act up more at bedtime. So when we think about the toolbox for managing the symptoms of uncomfortable legs at night, sometimes we'll use true restless leg type medications, Mirapex, drugs like the Requip. Sometimes we'll use antispasmodic drugs, baclofen, tizanidine. Sometimes if none of those work, we'll try pulling out something like quinine, which really is not specifically designed for either of those, but does work for just routine leg cramps that any of us could get. And it may be that this person really had a component of just non-MS related, non-restless leg related leg cramps playing off of some of the other neurological symptoms. So I'm glad they found some relief with something that's pretty benign.
Our next question comes from Terry. What is the treatment for a severe case of restless leg syndrome?
So true restless leg, we tend to use a class of drugs called dopamine receptor agonists. So these are things that were originally designed to treat Parkinson's disease. So they basically mimic what dopamine would do. So again, Requip, Mirapex would be the two most commonly used classes of drugs that are more specific to restless leg.
What causes a person to move from relapsing MS to primary progressive?
So that should not, so you can move from relapsing remitting MS to secondary progressive. So if we look at the natural history of MS, 85% of people with MS start with relapsing remitting, and without treatment, most people over time will slowly move into that secondary progressive category. Primary progressive is always by itself. So once you have primary progressive, you always have primary progressive. So that's a standalone diagnosis. Now, it could be that someone changed, the healthcare team changed that person's diagnosis and said, well, you know, I listened to your story and I think really you fit better with this, but it really, the disease itself should not switch to primary progressive.
All right, one more question. This one from Karen. How long do you wait to switch a patient 66 years old to Mavenclad, from Mavenclad to Ocrevus? Any concerns?
So Mavenclad, great drug, but it really, you know, so you do Mavenclad time zero. Now you do another dose a year later. And then the hope is, and what the data shows, is that people seem to be stable for long periods of time. We really don't know what the right thing to do is if someone is having breakthrough disease, let's say 4 years after Mavenclad. Could you redose with a smaller dose of Mavenclad? They do it in Europe. It's not the way that the drug is approved here in the United States. Or do you follow it with a different class of drugs like an Ocrevus? I think any of those things are open for discussion. But again, usually once you did Mavenclad, you usually think of someone being covered for long periods of time.
All righty. Let me have a look here. All righty. That brings us to the end of our time. If you missed any of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access recordings or to sign up for our newsletter to learn about upcoming events. Be here with us at 7 p.m. Eastern on Wednesday, November 10th for MS Couples, a care partner panel with host Sherry Benz. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Thrower. Thank you so much for the time you spent to prepare and share this information with us.
Thanks, everybody. Everyone stay safe.